Hi, my name is Anil Thapliyal. In my capacity as an adjunct professor, I'm leading the e-mental health and addictions portfolio at the Center for eHealth. E-mental health and addictions domain is sometimes also referred to as e-therapy or digital mental health by the industry. For the purposes of this presentation, I will use e-mental health addictions and e-therapy interchangeably. When we think about e-therapy, we often think of it as something which is very recent phenomenon, something which has started in the last decade or so. But there has been a very interesting paper by Dr. James Cartrine, Dr. David Ahern, and Dr. Stephen Locke titled Roadmap to Computer-Based Psychotherapy in the United States. That paper dates some of the early evolution of e-therapy treatment programs going back to 1966 by Colby and 1977 by Slack, using natural language typed in text as the primary patient input. That effectively marks 2016, this year, as 50 years ever since the first evolution of e-therapy programs in the world. While some brilliant e-therapy initiatives around the world are shining exemplars today, however, the challenge we face still today is embedding e-therapy programs fully within the integrated care pathways. Due to the disruptive nature of technological advancement, there have been interesting developments in the mental health and addictions domain, primary and secondary care, remote and rural health care, and engaging with the cohort of population that are not utilizing traditional healthcare system at all. Even National Aeronautics Space Administration, NASA, in the United States has made significant investment in developing e-therapy treatment programs for the astronauts flying in the long-duration flight missions. However, in New Zealand alone, since 2005, we have seen impressive uptake of newer ways of reaching out to mental health service users. These impressive initiatives range from National Depression Initiative for Adult Depression, fronted by our very own legendary all-black player Sir John Kirwan, the Lowdown for Youth Depression, Alcohol and Drug Helpline, Smoking Cessation, Gambling Helpline, and in primary care, Beating the Blues. All of these initiatives have been funded by the Ministry of Health. These newer ways of engaging with the mental health service users is not so much about innovation, but it is about speaking the consumer's language. The main challenges of e-therapy domain is the lack of integration with the wider healthcare continuum, lack of funding and planning, policy remit, workforce development, lack of understanding of complex supply chain and procurement processes, and many times uncoordinated approaches and duplication of some of these initiatives. Majority of these challenges have been noted in in-depth detail in the recent e-mental health addictions review undertaken by the National Mental Health Commission of Australia. To overcome these challenges, the Centre for eHealth has dedicated resources towards implementation science to effectively implement e-therapy initiatives in the real world. Towards that, we have commissioned yearly coming together of the top national and international experts in the e-therapy implementation science domain. This invitation-only expert symposium is held every year in New Zealand in September. To that effect, the Centre for eHealth is making dedicated efforts to commission better understanding of the implementation science and how we can better and more effectively implement e-therapy programs and services in the mental health domain. At the expert symposium, the following 5 core key components get discussed in in-depth detail by various recognized national and international experts. First and foremost, being the service user participation in the design, development, and implementation of e-therapy interventions. It goes without saying that the second key pillar is for e-therapy programs to have evidence-based medicine, ABM, pertaining to the effectiveness of the interventions. EBM aims to address the persistent problem of clinical practice variation with the help of various tools, including standardized practice guidelines. As a result, we have quite an in-depth involvement with the leading e-therapy scientific community within the academia to inform the development and deployment of these interventions. The third component is alignment with clinicians' actual workflow. How do we design, develop, and implement e-therapy programs which fit within the clinical workflow of actual frontline work settings? For that purpose, we have integral involvement of the clinicians working in the frontline, be it GPs, psychiatrists, social workers, counselors, administrators, or other professionals working in the frontline of mental health care provision. Just having an icon in the drop-down menu is not an assurance that clinicians are going to use it. There are aspects of workforce development, training, incentives, and integrated care pathways across the care continuum that need to be factored in. Fourth key component of the implementation science is partnership with the industry. What we are referring to here is very broad definition of industry, which includes organizations such as telecommunications organizations, ICT infrastructure providers, data aggregators, patient portal providers, EMR and PMS vendor communities, and system integrators. So we have to bring it all together in a cohesive manner for it to work effectively. Fifth, and perhaps the most important aspect for long-term sustainable development of e-therapy initiatives is an alignment with the national and regional policy, funding, and planning remits. And by that, what we mean is, if these initiatives are not aligned with the policy drivers of what the primary care, secondary care, or public health sector strategy wants to accomplish, then these initiatives will always exist in isolation and vacuum without any long-term baseline funding. Center for eHealth is proud to have formed an international partnership forum in e-mental health and addictions, implementation science, under the auspices of International Initiative for Mental Health Leadership. Its membership extends from New Zealand to Australia, United States of America, Canada, England, Scotland, Ireland, and Sweden.